Warm wishes to one and all. Myself, Dr. Akila Ganesh, Professor and Head from the Department of Public Health Dentistry, I'm here to present about the role of sleep time feeding practices in early childhood caries. Early childhood caries is a common public health problem and described by various names including nursing bottle caries, baby bottle tooth decay, nursing caries, and night bottle mouth. It is a significant global neglected disease of childhood with various consequences including early loss of teeth, prolonged poor food intake, poor general health, caries affecting the permanent teeth, poor aesthetics and self-esteem. The epidemiological death rate for early childhood caries includes a susceptible host, saliva and tooth structure through an agent, bacteria, and environment in the presence of refined carbohydrates over a period of time. The IAPT Global Summit on ECC held at Bangkok in 2018 has defined ECC as the presence of one or more decayed, missing or filled tooth surfaces in any primary tooth of a child below 6 years of age. It affects infants, toddlers and preschoolers and usually starts in the maxillary incisors. It has a global prevalence of 48% as described in a systematic review by Urub et al. In 2021 and a prevalence of 40.6% in rural South India. A systematic review on the prevalence of early childhood caries in India has reported 49.6% as the prevalence. A brief review of literature. Various systematic reviews have reported the various risk factors which are associated with ECC. Harris et al. In 2004 has defined 106 risk factors including socio-demographic, dietary, oral hygiene and breast and bottle feeding. While Kirtika et al. Recently in 2018 has reported 123 risk factors including enamel defects, high levels of Streptococcus mutans and dentinal caries. An umbrella review on the risk factors by Lee et al. In 2021 has reported enamel defects, high levels of Streptococcus mutans, dentinal caries, increased soda consumption, daily intake of sugary snacks and obesity as risk factors for early childhood caries. A brief review of literature. Breastfeeding at night and after 12 months has reported to be associated with ECC by Validis, Feldens, Cato, Tam and Q. While bottle feeding and the contact time between the milk and teeth as reported as risk factors by Jin, Ullenham, Tam, Chaffee and Nupur. Streptococcus mutans in sweetened drinks has been reported as risk factors by CO, Felden, Plonka, Kirtika and Lee in 2021, while enamel opacity has reported as risk factors by Lay, CO et al., Kirtika and Lee et al. In 2021. Diminished flow of saliva is associated with ECC as reported by Kim in 2021 with diminished tongue movements by Nupur et al. In 2022. The prolonged contact time and demineralization as reported as risk factors by Huang, Farooq and Nupur, while enamel breakdown as reported as risk factors by Coffey. The lacunae in literature has reported that sleep time feeding practices includes both nighttime and daytime, but literature lacks data on the relationship of sleep time feeding practices with ECC. Hence, there is a need for an exclusive study of sleep time feeding practices among toddlers. The objectives of this study was to determine the association between sleep time feeding practices and early childhood caries. So we had constructed something called the FEAST or the Feeding at Sleep Time Scale, which included 4 broad constructs of breastfeeding, bottle feeding, other feeding modes, and the tooth and the diet construct. The unique feature of the FEAST scale is that it had recorded breastfeeding both before and after the introduction of solids, as well as bottle feeding both before and after the introduction of solids. Also, 3 sleep time feeding practices have been reported through the FEAST scale. One is feeding at the beginning of sleep, which means feeding through any mode while going to sleep. Feeding during early morning sleep, which means feeding early in the morning followed by a small nap for a few hours before active waking up. And feeding during the course of sleep, which means feeding during the sleep time, excluding the beginning and early morning sleep. Feeding during the course of sleep can include all bedtimes, including naps, all night bedtimes and occasional naps, all night bedtimes but not naps, all naps and occasional night bedtimes, all naps but not night bedtimes, and occasional bedtimes including naps. So this represents a systematic development of the feast scale, the four broad constructs with the various items under each of the scale. This was developed following the methods of qualitative research methodology. So methodology involved in our study was a case-controlled study on toddlers. Informed consent was obtained from the parents. It was in the local vernacular language Tamil. Ethical clearance was obtained from the institution, and a single investigator performed face-to-face interviews with the parents of the children. The child's demographic details were obtained, while the parent's socioeconomic status was recorded using modified Kupasamy scale. Early childhood caries was recorded using International Caries Detection and Assessment System 2007. So this is the ethical approval from the institution, and this is a sample of the informed consent form. So the methodology, it was carried out in 4 study sites, which includes the Rural Health and Training Center at Vailanallur, the Urban Community Health Center at Chinnaporu, and the Pediatric Outpatient Departments of the Public Medical Center and the Private Medical Center. So this briefly describes the methodology. So we recruited children from each of the study sites. The purpose of the study was obtained, and once informed consent was obtained and they agreed, and the child was physically and mentally stable, we included them in the study. So the questionnaire was asked as described earlier with the dental caries examination for ECC. And if caries was present, they were included as a case. If caries was absent, they were a control, for whom oral hygiene instructions and anticipatory guidance was given. If caries was present, it was recorded using ICTA scale and referred to pediatric dentistry for further treatment. And if they did not give informed consent, they were excluded from the study. However, we did give them a dental health examination, oral hygiene instructions and anticipatory guidance if the patient was willing and the child was cooperative. And in case dental care was needed, they were referred to the Department of Pediatric Dentistry. So the sample size was calculated based on a study done by Mahesh R. et al. With a power of 80% and alpha error of 5%, and was arrived as 132 in each group. We included 2 age groups in this. One is 12 to 24 and 25 to 36 for 2 reasons. One being the different feeding habits between the 2 age groups, as well as the different type of dentition in both the age groups. The 12 to 24 months is usually when it is the erupting stage of various teeth of the primary dentition, while 25 to 36 months the teeth are almost erupt. So we rounded 132 to 150, so 150 cases and 150 controls in each of the age groups. So the eligibility criteria, inclusion criteria included healthy toddlers free of systemic illness and toddlers of mothers who gave consent. The exclusion criteria were toddlers with congenital anomalies, physical or mental disabilities, uncooperative children, and mothers who could not understand Tamil. So the statistical package for social sciences SPSS version 21 was used. The feeding practices were recorded using the fee scale, for which the Pearson chi-square test was used, and the association between the cases and the controls was established using odds ratio. And statistical level of significance was set at p-value less than 0.05. So moving on to the results, we found that, this tells about the distribution of the study participants. So we had an almost equal distribution of 314 in the 12 to 24 months and 313 in the 25 to 36 month year group, and a total of 302 cases and 325 controls, having a total sample of 627 toddlers. So this was the distribution between the 4 study sites, and this was the distribution among the socio-economic status. We combine the upper and the upper middle group and the lower middle and the upper lower socioeconomic status group. So now on seeing the breastfeeding construct, we found that the children who had before introduction of foods, the cases were 300 while the controls were 321. While after introduction of solids, 266 cases continued breastfeeding while 288 controls were continuing breastfeeding. So as long as the bottle feeding construct was concerned, after introduction of solids, 206 cases were bottle fed while only 139 controls were bottle fed. And seeing the use of other feeding modes like the sipper, tumbler, palade, etc., there were 176 cases while 204 controls. So again, this shows the number of the sleep time feeding patterns which was practiced by the cases and controls. We see this was for the breastfeeding. We find that in all the 3 sleep time feeding patterns, which is beginning of sleep, early morning sleep and in between sleep or the course of sleep, the cases outnumbered the controls. Similarly, for the bottle feeding construct also, the cases outnumbered the controls in all the 3 sleep time feeding patterns. This was the other feeding modes. Here also we have a similar results where the cases have outnumbered the controls. And we also assess the intake of solids during the course of sleep, where the child wakes up in between the sleep and he cries and is given a biscuit or a banana to feed. In that we had almost 3 to 4 times more cases when compared to the controls. And addition of sweetener to bottle was also found to be significantly more in the cases than in the controls. So this table describes the odds ratio for breastfeeding bottle feeding construct with regards to the 3 sleep time feeding patterns. So we find that there was an odds of 6.7 for the beginning of sleep for breastfeeding, while there was an odds of 8.3 for bottle feeding construct when the child was fed during the course of sleep. Also, we notice that sweeteners reported, the use of sweeteners means when you add sugar or any other form of sweetener to the bottle, the cases had the cases to controls had an odds of 2.84. As we already said, the intake of solids during sleep also reported a significant odds of 6.02. All these results were statistically significant with a p-value of 0.001. So moving on to the discussion, this study is the first of its kind to describe and report sleep time feeding practices, and there is a strong association between sleep time feeding practices and ECC. While seeing the breastfeeding construct, beginning of sleep was reported more at risk than the course of sleep or early morning sleep. While in the bottle feeding, it was the course of sleep reported to be at higher risk than the beginning of sleep and early morning sleep. So increased frequency and duration with an increased contact time and the softening of enamel. So what happens is there is the equilibrium between the remineralization and the demineralization gets disturbed. Thereby there is more chance of progression of ECC. This was reported by Sullivan et al., Feldens et al. And Catu et al. So again, addition of sweeteners or any other additive like this health drink like the Boost, Horlicks or whatever, which also have inherent sweeteners in them. So what happens is there is more chance for bacteria to thrive. Thereby it will lead to demineralization with a lack or diminished remineralization, thereby eventually leading to early childhood caries. Okay, so bottle feeding after 12 months was associated with ECC as reported by Hallenstein et al. And Horowitz et al. However, Jin and Curran study did not report such an association. Hypoplastic areas are those which decreased mineralization and increased porosity. So thereby there are irregular surfaces. So what happens is there is more accumulation of colonies of Streptococcus mutans on such surfaces. thereby leading to more enamel breakdown and thereby early childhood caries. So moving on to the strengths and limitations of this study, we have included a large sample size of 627, and there was an also equal distribution between the 12 to 24 and the 25 to 36 month old children. We have recorded the retrospective sleep time feeding practices of the child since birth. In the sense, even if we recorded a 25-year-old child, we have recorded all the practice the child has been doing since birth. We have included a varied socioeconomic strata, and the toddlers were chosen for this because the primary tooth would have been exposed to the oral environment for at least 6 months post-eruption. And we have used IGDA scoring system, which thereby facilitates even the early detection of carious lesions, and hence we can plan therapeutic care. However, the limitations include generalizability of the results is questionable because it is a lack of population-based sample. Record bias on the part of the mother could have occurred. Self-reporting bias by the mother could have also occurred. And apart from caries and the night feeding, there are various other factors which have been involved in caries which were not being captured. So to summarize, sleep time feeding practices have a strong association with early childhood caries, and sleep time breastfeeding has reported 6 times more at risk, while sleep time bottle feeding has reported 8 times more at risk for early childhood caries. So the future directions, long-term prospective studies using the fee scale might help to address the limitations of a case control study. And more large-scale community-based epidemiological studies at a global level using fee scale will further enhance the strength of the role of sleep time feeding practices in early childhood caries. So this has been published in Caries Research, a reputed journal with an impact factor of 4.056. So these are my references. And I would like to acknowledge Sri Ramachandra Institute of Higher Education and Research, who supported us with the GATE Young Faculty Research Grant for the year 2018-19. And I would also like to thank the organizing committee for having given me this opportunity. Thank you all.